Good afternoon, everyone. My name is Carjan Paul Elgailoa, and I'm proud to present our grand case presentation entitled Flipping the Count from Low to Let's Go, a grand case presentation on myelodysplastic syndrome. For the outline of our presentation are the following: objectives, general data, history and physical examination findings, primary working impression, differential diagnosis, pathophysiology, course in the ward, final diagnosis, and management. Objectives. Our general objective is to present a case of a 54-year-old female presenting with pancytopenia. For the specific objectives, to discuss the approach in the diagnosis of a patient with pancytopenia, to discuss the differential diagnosis, and to present an evidence-based management of this patient. Identifying data. Presenting to you, patient CL, 54-year-old female, married, a Seventh-day Adventist from Pango Ipil, Zamboanga, Sibugay. For the history of the present illness, from 6 to 8 weeks prior to admission, patient complained of easy bruisability and gingival bleeding associated after a dental cleaning session. 2 days prior to admission, onset of body malaise, and on the day of the admission, persistence of symptoms prompted the patient to seek for a general checkup. From the previous week up until the day of admission, no meds were taken and no consult was done. For the past medical history, the patient had no previous hospitalization and major surgeries, no known comorbids, no maintenance medications being taken, and the patient is allergic to NSAIDs. For the medical history, the patient has a known family history of hypertension on both maternal and paternal side, no known family history of diabetes mellitus and many other comorbids. For the personal and social history, the patient is a Seventh-day Adventist, works at Zamboanga Peninsula Mission Health Ministry, and a mother of one and married to MC, a 49-year-old male, and the patient is a non-smoker and non-alcoholic drinker. For the personal and social history continuation, the diet of the patient consists of vegetables, fruit, and rice, and fond of eating fried and sweet foods, and occasionally eats meat. For the review of systems, the rest are unremarkable except for the body malaise, headache, gingival bleeding, and easy bruising. Here's the physical examination of our patient. For the patient's general survey, the patient was awake, alert, conscious, coherent, and not in respiratory distress. The vital signs are essentially normal. And as for the anthropometrics, the BMI for our patient is 16.1, which is below the average. For the skin, multiple ecchymosis were noted on the lower extremities. Other than that, the patient had essentially normal skin presentation. For the HENT, for the head, smooth hair texture, normocephalic, atraumatic, no lesions. For the eyes, anectatic sclerae, pale palpebral conjunctiva, and the visual field was full by confrontation, and the extraocular muscles were intact. Ears had no lesions, no discharges. For the nose, pink mucosa, septum at midline, no sinus tenderness, and for the throat, the patient had a pale oral buccal mucosa. For the neck, essentially normal, and as well as for the chest and lungs. Essentially normal as well for the heart. For the abdomen, flabby, no scars, normal active bowel sounds, mostly tympanitic upon percussion, soft, non-tender, no masses, and no organomegaly noted. For the extremities, pale nail beds, no edema, capillary refill time of less than 2 seconds, and equal peripheral pulses. These are the salient features of our patient. The patient is a known 54-year-old female, no known comorbids, allergic to NSAIDs, presents with body malaise, and there is a decrease in meat intake. For the objective data, has pale conjunctiva, pale nail beds, hemodynamically stable with a BP of 90/60, heart rate of 85, febrile and underweight with a BMI of 16.6. For the problem list, we have body malaise, easy bruisability. Let's now talk about the differential diagnosis of a patient presenting with body malaise. Now we can consider autoimmune causes and non-autoimmune causes. For the autoimmune causes, we have acquired aplastic anemia, systemic lupus erythematosus, myelodysplastic syndrome, and hemolytic anemia. For the non-autoimmune causes, we have infection, hematologic, and metabolic causes. For the autoimmune cause, we have the acquired aplastic anemia. This is more likely since the patient is presenting with body malaise, which occurs in around 80 to 90% among different patients, with a history of easy bruisability and bleeding. Pallor, which occurs in around 40 to 50% of these patients, and also ecchymosis on lower extremities. However, our patient has no known exposure to radiation and toxin. Thus, acquired aplastic anemia is less likely. For systemic lupus erythematosus, this is more likely since body malaise would present in around 50 to 70% among patients and history of easy bruisability and bleeding. It also occurs in around 20 to 40% that would present with pallor and also ecchymosis. However, SLE is less likely in this case since the patient is not presenting with other constitutional symptoms such as alopecia and joint pains. The patient is also febrile during physical examination and no jaundice was noted, which is usually associated with hemolytic anemia. Thus, to rule out systemic lupus erythematosus, we can do additional tests such as Coombs test, ANA, and anti-dsDNA. Now, we can also consider myelodysplastic syndrome for this patient. Body malaise would also occur in around 50 to 70% of patients with a history of easy bruisability and bleeding, and also with pallor and ecchymosis. However, we can only completely rule out myelodysplastic syndrome with a bone marrow biopsy for confirmation. Let's now talk about the non-autoimmune causes of body malaise. First off, we have dengue fever. So for dengue fever, they would also present with body malaise, easy bruisability and bleeding, pallor, and ecchymosis. However, this is less likely for this patient since the history of fever and chills of this patient occurred 2 months ago, and the patient was febrile during physical examination. Another infectious cause of body malaise would be the human immunodeficiency virus. Same reason why we're ruling this in as our differential diagnosis. However, HIV is less likely in this case since the patient has no history of multiple sex partners. We'll also rule out hepatitis C since the patient does not have any history of multiple blood transfusion and multiple sex partners. Bone marrow tuberculosis can also cause body malaise, pallor, and ecchymosis, and history of easy bruisability. However, we can only completely rule this out with the bone marrow biopsy to be submitted for gene expert. We can also consider megaloblastic anemia since the patient is at risk for developing this condition. Because for the risk factor, the patient only has low meat intake. And in patients with megaloblastic anemia, they usually present with body malaise in around 70 to 90% of patients, and also with pallor in around 60 to 80% of patients. However, for megaloblastic anemia, it does not always present with easy bruisability and ecchymosis, and we can only completely rule this out with vitamin B12 measurement. You can also consider iron deficiency anemia in the same reason with megaloblastic anemia. However, just like megaloblastic anemia, it does not always present with easy bruisability and ecchymosis. We can only completely rule this out by doing supportive tests such as reticulocyte production index, transferrin, and serum ferritin. Hypothyroidism can also cause body malaise and pallor. However, in this patient, this is less likely since the patient has not been complaining with cold intolerance, and the patient had no neck masses during physical examination. However, to completely rule this out, thyroid stimulating hormone levels may be checked to completely Rule out hypothyroidism. For hypokalemia, it can also present with body malaise. However, this is less likely since the patient has no known history of taking potassium-wasting diuretics such as furosemide, and the patient did not complain of leg cramps. To completely rule this out, we can check the serum potassium levels of this patient. In hypocalcemia is less likely since the patient has not been complaining with perioral numbness. There was no observed Vostex sign during physical examination, and there's negative Trousseau sign. So to completely rule out hypocalcemia, we can check the serum calcium levels. Now let's talk about your myelodysplastic syndrome pathophysiology. So your myelodysplastic syndrome is a clonal hematopoietic stem cell disorder. So it can cause pancytopenia and bone marrow hypercellularity. Now, what are the different causes of myelodysplastic syndrome as our primary working impression? So, first cause of your myelodysplastic syndrome is idiopathic. Next, we have treatment-related myelodysplastic syndrome and environmental toxins. And these three would eventually lead to acquired somatic gene mutations. Now, another cause of the MDS is familial disposition, which can cause the inherited germline gene mutations. So both of these mutations, especially for germline gene mutations, the common mutations involves your GATA2 and RUNX1. So all of these gene mutations would eventually lead to the alterations in protein functions with or without chromosomal abnormalities in the hemopoietic stem cell. Now this would further lead to stem cell differentiation problems, which will eventually cause the aberrant bone marrow cell accumulation, thus leading to myelodysplastic syndrome. So for myelodysplastic syndrome, how does it cause or affect all of the three cell lines? Now, for myelodysplastic syndrome, clonal expansion of the abnormal cells in the bone marrow is going to cause the apoptosis of clonal cells, which inhibits granulocyte, monocyte, and RBC and platelet development. This will eventually lead to a reduced mature functional blood cells leaving the bone marrow, which will eventually cause the reduced cell numbers in one or more cell lines. So there's also a decrease in your red blood cell, eventually causing anemia, which will cause the decrease in transport of oxygen to tissues and a decrease in red color of the blood. This explains why our patient has been presenting with fatigue or body malaise and pallor. Another cell line that would be affected would be the decrease in white blood cell, which is called leukopenia, which will eventually cause a decrease in capacity to fight infections, thus explaining or causing recurrent infections. Myelodysplastic syndrome can also cause a decrease in your platelets, thrombocytopenia, causing a decrease in blood clotting ability, leading to easy bruisability and bleeding, which explains the ecchymosis of our patient, which was noted during physical examination. Now let's talk about the course in the ward. I'll now be discussing the course in the ward. So our approach for the discussion in the course in the ward is in the form of the concept map. So patient CL, for the general data, patient CL, 54-year-old married female, Seventh-day Adventist from Ipil, Zamboanga. So let's start with the pertinent history in this concept map. So as I've mentioned earlier, the patient had a history of easy bruisability and gingival bleeding and a history of fever. However, the patient had no history of multiple sex partners and prior multiple blood transfusions, which makes hepatitis C and HIV as a cause of the patient's condition less likely. Now, if we're going to look at the pertinent physical examination findings, you have ecchymosis and pallor. So we have our initial laboratory findings of bicytopenia, in which we have an RBC of 1.73 times 10 to the power of 9 per liter, and a platelet count of 20,000. So that is anemia plus thrombocytopenia. So for the chief complaint, body malaise, as I've mentioned earlier during my differential diagnosis, we have the autoimmune causes and the non-autoimmune causes. Now, let's start with the hospital day 0. During the hospital day 0, these are the significant laboratory findings. We have a CBC with platelet, which yielded in MCV, or mean cell volume. So the normal mean cell volume is at around 80 to 100 femtoliters, and the patient's result was actually 109 femtoliters. So since there's an increase in the MCV of the patient, this could mean that the patient has macrocytic red blood cell. The causes of your macrocytic red blood cell would be aplastic anemia and megaloblastic anemia, which we have already ruled in earlier. However, with the patient's MCV, we can already rule out iron deficiency anemia, because in iron deficiency anemia, the MCV should have been decreased or even normal. So other clinical findings during hospital day 0 is a negative Trousseau sign and negative Vostek sign. So from this, we can safely say that hypocalcemia as a cause of body malaise is less likely. So let's now proceed to hospital day 1. As for the hospital day 1, peripheral blood smear was done for this patient with the following findings: RBCs or macrocytic and normochromic. So the platelets are rarely seen. So these findings actually supports our initial differential diagnosis of megaloblastic anemia. Another significant finding during hospital day 1 is the normal serum potassium, which can help us rule out hypokalemia. Thus, in this patient's condition, hypokalemia is less likely. Now, if the primary management of this patient at this point is the blood transfusion and platelet transfusion. And over the course of the ward, there were CBC with platelet were serially taken, and depending on the result of these lab tests, the management, which is the transfusion of red blood cells and platelet concentrate, were continued. As for the hospital day 2, the significant result here is the reticulocyte count of 0.322, which is actually consistent with aplastic anemia. Now, other tests included in hospital day 2 would be the dengue NS1 and the dengue duo test. Now, for dengue NS1 and dengue duo test, dengue NS1 was actually negative, and the dengue duo test came out positive, both IgG and IgM. Now, even though that the dengue duo test came out positive, this is still less likely to be dengue fever, because again, as what was mentioned during the differential diagnosis, the febrile presentation of this patient occurred months ago, okay, as opposed to the usual temporal profile of a patient with dengue fever, which actually usually presents with a fever of in around 4 to 5 days prior to the patient's hospitalization. And another thing is, one thing that would also explain the reason for the positive result of your dengue duo is that it is highly possible that this patient also has a concomitant autoimmune disease. Hence, if we're going to look at the Coombs test of this patient, the patient's Coombs test came out positive in the direct Coombs test. Thus, if you have a positive Coombs test result, this would actually mean that the patient would have autoimmune hemolytic, which is a supporting finding of systemic lupus erythematosus. So in systemic lupus erythematosus, it is possible for these patients or any other autoimmune diseases to yield a positive result, a false positive result in dengue duo test. Now at this point in time, We are now ruling out dengue fever and ruling in systemic lupus erythematosus as the cause of a patient's autoimmune condition. At this point, the blood transfusion and platelet concentrate transfusion was also ordered due to the consistently low blood cell counts of our patient. For the hospital day 3 to 5, CBC and platelet monitoring was continued, and for the hospital day 6, the TSH of the patient was taken, and the thyroid stimulating hormone levels of our patient was actually at 2.62 international units per ml, which means this is normal, in which result we can already rule out hypothyroidism. If we're going to look at the indirect bilirubin of our patient, the indirect bilirubin level of our patient is 11.71 micromoles per liter, which is actually normal. And since the indirect bilirubin was normal, we can also rule out hemolytic anemia, because in hemolytic anemia, there's an increased production of bilirubin due to the increase in breakdown of RBCs, which would consistently yield an increase in indirect bilirubin. Now, in this case, if we're going to go back to the patient's physical examination, the patient did not present with jaundice, and at the same time had a normal indirect bilirubin, so now we can safely rule out hemolytic anemia in this case. Now we have the hospital day 7 to 10, in which the CBC and platelet monitoring was continued, and then blood transfusion and platelet concentrate was continued accordingly. Now at this point, the disease that we're going to that was focused on for our patient is the systemic lupus erythematosus. This explains why, starting from hospital day 4, the patient was given dexamethasone due to the positive Coombs test result. Because in a positive Coombs test result, it would mean that the patient has an underlying autoimmune disorder. So since if you have an autoimmune disorder, the problem there is due to the hyperreactivity of the immune system of the patient. And in order to curb the response of the immune system of our patient, we have to give dexamethasone as our mainstay management. Now for hospital day 11, the ANA results of our patient came out, which yielded a positive result, which actually strengthens our diagnosis of systemic lupus erythematosus. However, if we're going to observe the blood cells of our patient coming from hospital day 11 up until hospital day 12 to 14, the blood cells of our patient remained consistently low. So what would make us think at this point is that why is it that this patient, despite receiving dexamethasone, which can actually help or curb the immune response of the patient, in which the patient still did not respond to this treatment due to the consistently low blood cell lines. So the next thing that we can do is to order the other supportive tests to confirm systemic lupus erythematosus, which are C3 and anti-dsDNA. Thus, if we're going to look out for the results of these supporting laboratory tests on hospital day 15 and hospital day 20, for the C3 or the serum complement of our patient was actually normal. And if we're going to look at the anti-dsDNA, it actually came out negative. So in this case, we can rule out systemic lupus erythematosus. Now the dilemma here is that what else can cause a problem in all of these 3 blood cell lines, pancytopenia, aside from an autoimmune disorder such as systemic lupus erythematosus. That is why the decision was actually made to do a bone marrow biopsy. And another reason why we have to strongly rule out systemic lupus erythematosus, because aside from giving dexamethasone, the patient was actually also given with other treatments for systemic lupus erythematosus, such as hydroxychloroquine. We also have the cyclophosphamide and the methylprednisolone pulse therapy. And in all of these therapies, the patient remained to be pancytopenic. Now, by ruling out systemic lupus erythematosus, we have to explore for other causes of pancytopenia, only which the bone marrow biopsy can confirm. Now, The remaining differential diagnoses would then be the aplastic anemia, myelodysplastic syndrome, and bone marrow tuberculosis. Now, on hospital day 21, the bone marrow biopsy was performed, and then on the hospital day 22, the samples were actually sent. So the other half of the sample, the bone marrow aspirate, was sent to another laboratory for evaluation, and another one was actually sent to the TB dots for gene expert. Now, if we're going to look at the result of the biopsy, the bone marrow biopsy aspirate, the BMA gene expert result in the TB dots was actually negative, in which we can already rule out bone marrow tuberculosis. Now, as for the other biopsy result, it yielded adequately cellular and polymorphous bone marrow with dysplastic features, which is more consistent with myelodysplastic syndrome in contrast with your aplastic anemia. Thus, in this case, based on the reset biopsy result, our final diagnosis would be myelodysplastic syndrome confirmed. Now, based on this result, we can already rule out aplastic anemia. Let's now discuss the bone marrow biopsy result. So for the histopathologic diagnosis, the patient has adequately cellular and polymorphous bone marrow with dysplastic features. And we're going to show these features in the following slides. So this is the first slide taken in the bone marrow biopsy, and as you can see, there is adequate cellularity, 40% cellularity. Now in this next slide, you're going to see the abnormal looking cells with abnormal nucleation of the erythroids. So in this case, we also have the hypolobated megakaryocyte, which actually signifies the abnormal maturation of the platelets. We can also see here in this slide the Pelger-Ruet cells, which are the abnormally shaped nucleus of the white blood cell, which also signifies abnormal white blood cell maturation. And there's an increase in erythroid versus myeloid ratio. So in another slide, we see here the abnormally shaped cells, which are consistent with dysplastic, which we call this dysplastic cell. So in this specific cell noted in this slide, we have an abnormally looking nucleus. So those are the different results of the bone marrow aspirate, which is consistent with myelodysplastic syndrome. So for the final diagnosis, myelodysplastic syndrome. Now, to manage a case of a myelodysplastic syndrome, let's first talk about the correction of pancytopenia. So let's talk about hypomethylating agents. Now, in this study, the efficacy of the allogenic hematopoietic stem cell transplantation was compared against hypomethylating agents in patients with myelodysplastic syndrome. In a specific study, the population was around 93 adult patients diagnosed with myelodysplastic syndrome. Now, for the intervention, the allogenic hematopoietic stem cell group has a total of 53 patients versus hypomethylating agents of either azacitidine and decitabine of 40 patients. Now, for the outcome, we're going to observe the time to relapse and overall survival rate of these patients. Method used in this study was retrospective case control study, which was done from January 1988 to April 2008. Now for the outcome, if we're going to compare the median time to relapse or months, okay, for the allogenic stem cell therapy group, okay, their median time to relapse was actually at 9 months. And for the hematopoietic stem cell, the hypomethylating agents group, the median time to relapse was around 15 months. Therefore, if we're going to compare in terms of median time to relapse or months, the hypomethylating agent group has a better effect. Now, in terms of 4-year survival rate, the 4-year survival rate represent of the patients under the hematopoietic stem cell group, they have 24%, and for the 4-year survival rate among patients with hypomethylating agents, they have a 23%. Therefore, their 4-year survival rate percentage is non-significant. So there's no major benefit for upfront allogenic stem cell therapy when compared with the treatment with hypomethylating agents. Now, since there's no significant difference between stem cell therapy and hypomethylating agents, we're going to go with the use of hypomethylating agents in this case. Since for our patient, it would be difficult or challenging to look for a donor for the stem cell therapy, when in fact we can just give these hypomethylating agents in place in order to correct the pancytopenia. Now, we have two available hypomethylating agents. These are azacitidine and decitabine. So which one would be better for our patient? Now, in this study, the comparison of both medications for patients with myelodysplastic syndrome and acute myeloid leukemia, this journal has a population of 1,072 MDS patients versus 1,256 AML patients. Now, for the intervention, azacitidine was compared against decitabine as monotherapy. Now, for the outcome, we're going to observe the overall survival rate and the incidence of adverse events. Now, for the method used, they use Markov chain Monte Carlo method and meta-analysis. Now, the significant result of this meta-analysis is that if we're going to see the survival rate for patients with MDS, azacitidine has a significantly greater survival rate compared to that with decitabine. Now, on the other hand, if a patient has acute myeloid leukemia, the decitabine has a higher survival rate compared to that of azacitidine. Therefore, for a patient diagnosed with myelodysplastic syndrome azacitidine has would yield a better survival rate for our patient. Thus, for the conclusion, results showed that AZA is better choice than DAC in patients with MDS, and in comparison, AML patients, DAC or decitabine have more benefits. So for the correction of the pancytopenia for our patient, we're going to choose azacitidine. So how does azacitidine works? So it actually acts on the cell cycle of the bone marrow cell. So they act by removing the methyl group of these cells. So by hypomethylating these cells, they're going to correct the abnormal maturation. And through this, there is an increase in replication of these normal cells, thus correcting the pancytopenia of our patient. So we say correcting the pancytopenia, it can help in increasing the red blood cells of our patient, the white blood cells, and the platelet count. So how do we give azacitidine? For the dose, the initial dose is at around 75 milligrams per body surface area daily via subcutaneous injection or IV infusion for over 10 to 40 minutes for 7 days. This is actually followed by a rest period of 21 days over a 28-day cycle. And this dose can be increased to up to 100 milligrams per body surface area daily if there is no benefit for after 2 cycles, given that there are no adverse reactions. Now, it is recommended to use azacitidine as a treatment with a treatment duration of a minimum of 4 to 6 cycles and can be continued as long as the patient benefits. Now, We're already done with the correction of the pancytopenia. Let's now talk about the thrombocytopenia-related bleeding events of our patient, especially since the patient has already been presenting with gingival bleeding and AC bruisability and ecchymosis. So at this point, we're going to talk about the thrombopoietin mimetics. So what are these medications? So we have one study here which was about the thrombopoietin mimetics for patients with myelodysplastic syndrome. Now, in this specific study, the population was 2,000 MDS patients of all risk groups without gender, age, or ethnicity restrictions. Now, for the intervention, thrombopoietin mimetics were used, both romiplustim or L-Thrombopag, versus a placebo group of around 1,000 patients. Now, for the outcome, we're going to compare the mortality or transformation to AML, incidence of bleeding events, transfusion requirements, and all adverse events in these patients between those receiving thrombopoietin mimetics versus those who does not receive these medication. For the method, what was done was randomized controlled trial for 28-day cycle to 6 months and more than 58 weeks. So the results show that there is a significant decrease in bleeding events in those patients receiving thrombopoietin mimetics. And as for the adverse events, there are actually less adverse events for those who are receiving thrombopoietin mimetics. Therefore, for the conclusion, so the meta-analysis showed that there is little or no evidence for a difference in the mortality during the study and the premature progression to AML. So treatment with TPO mimetics resulted in lower number of MDS suffering from bleeding. So for the management of the thrombocytopenia of our patients, we're going to use romiplustim, which is in Fc peptide fusion protein or peptibody, and is a TPO receptor agonist. So how does it increase the platelet? It binds to the human TPO receptor known as CMP1 and activates intracellular transcriptional pathways to stimulate platelet production. So for the romiplustim, the initial dose is at around 1 microgram per kilogram once weekly and may be increased by increments of 1 microgram per kilogram until a platelet count of more than or equal to 50,000 is achieved and maintained. So the max dose is at around 10 micrograms per kilogram once weekly. Now, we're going to talk about erythroid maturation agents for the correction of anemia and the reduction of need for regular red cell transfusions. Now, in this case, the erythroid agonist that we're going to use is the luspatercept. This study, it discusses this medication used in myelodysplastic syndrome. For this study, 229 patients with very low risk or intermediate risk myelodysplastic syndrome were included in this study. For the intervention, luspatercept 1 to 1.75 milligrams per kilogram subcutaneous injection every 3 weeks was done for the interventional group versus a placebo of 76. So for the outcome, we're going to compare their transfusion independence. Method done here is the double-blind study, placebo-controlled, randomized controlled trial done for around 48 weeks. Now in this study, we can see in this result that in patients receiving erythroid agonists, the erythroid response was increased for the first 1 to 24 weeks for those patients receiving luspatercept. Now, the number of patients whose erythroid response increased was at around 81% for those receiving luspatercept versus the 9 patients who only had minimal erythroid response for those in the placebo group. So in all other parameters, those receiving luspatercept has an increase in erythroid response versus those in placebo was only few patients with minimal response. So for the conclusion, luspatercept reduced the severity of anemia in patients with lower risk myelodysplastic syndrome and those who have been receiving regular red cell transfusion and who had disease that was refractory or unlikely to respond to erythropoiesis stimulating agents, or those who had discontinued such agents owing to an adverse event. Now, we're going to use luspatercept in our patient because as you've noticed, over the course of the wards of the patient, we have been continually transfusing the patient with RBC, packed RBCs and platelet concentrate transfusion. Now the problem with this multiple packed RBC transfusion is that it's going to eventually cause blood transfusion reactions in the long run. Especially in our patient, the patient already manifested rashes in response to these multiple blood transfusion. That is why it is very important for us to also cater to this issue of our patient. This also this justifies the use of luspatercept. Now for the luspatercept, the initial dose is at around 1 milligram per kilogram once daily, once for a subcutaneous injection every 3 weeks, once every 3 weeks. Now for the luspatercept dosing, take note that we should not increase the dose if an adverse reaction occurs. So the titration of the dose is based on insufficient response. So those the dosing titration is already flashed on the screen. So dosage modifications for pre-dose hemoglobin levels or rapid hemoglobin rise. So for the pre-dose hemoglobin of more than or equal to 11.5 grams per deciliter in the absence of transfusion, you interrupt dose is to restart when the hemoglobin is less than or equal to 11 grams per deciliter. So we can increase the dosing in patients with a hemoglobin of more than 2 grams per deciliter within 3 weeks in the absence of transfusions, and the following doses or the dosing titration is already flashed on the screen as well. So that would be all for the management of a patient with myelodysplastic syndrome. So thank you so much for listening and we highly appreciate your feedbacks.